Welcome back, everybody. Please take your seats, and just a quick reminder to silence your cell phones. I am delighted to welcome to the stage Jocelyn Ulrich, the Deputy Vice President of Medical Innovation for Policy at Pharma, and she will be joined by Bob Cusack, Editor-in-Chief of The Hill.
Thanks, Julie. Thank you, Jocelyn, for joining us this morning. We're talking a little bit backstage about before COVID came along, and correct me if I'm wrong, the quickest vaccine was Ebola, and that took about 5 years. So really looking at what has happened is remarkable, is historic. We all want COVID to go away. It's not gone away. But certainly there have been significant advantages of what's happened. So take us, first question, take us behind the curtain with your industry. How has it been?
It has been an all hands on deck, race to try to get the vaccines together, to get therapeutics together. Scientists collaborating, public-private partnerships, incredible innovation, incredible speed, partnering with the FDA in order to get guidance out quickly, in order to understand how to do vaccine development in parallel. So you talked about 5 years. We were able to get a vaccine far faster than that.
Right.
Incredible times because we were able to run certain processes in parallel. So there were a lot of really amazing learnings in how we did this and how to do drug development efficiently. And I think the industry has just really had its moment in terms of leveraging science and figuring out how to deliver for patients.
And have you sensed that with government agencies and regulators in industry, there's always a tension. There'll always be one. But was it one of mostly, pretty good collaboration with the federal government to have such a success story of creating vaccines and multiple vaccines?
Yeah, this was absolutely a success story in terms of the ability to get rapid feedback from the regulatory agencies. Operation Warp Speed, which was able to provide some de-risking to certain companies in order to encourage them to get more shots on goal. There was, again, public-private partnerships, both among companies and public sector. So yes, it was a very good time, I think, for collaboration, all hands on deck.
Going forward now, this country is still, and the world, going through some major supply chain issues. Where do we need to go? What do policymakers, in your view, need to do to meet those challenges?
So I think one of the things we've really seen is that companies were able to create the supply, but we are having a lot of challenges right now in that last mile distribution. We're still having challenges getting the shots in arms. And so countries need to be thinking about how do we prepare for that next pandemic? How do we ensure that there's the right workforce in place, the right policies to make sure that people are able to administer the vaccines, and the right incentives for manufacturers to continue to be able to step up quickly for the next pandemic.
Yeah, Mitch McConnell, the Senate Minority Leader who survived polio, said he was perplexed and surprised that so many people were resistant to the vaccine. Were you?
I mean, it's heartbreaking how little trust in science we have seen. I think there were trends maybe that we saw, but the COVID pandemic really shone a light on this real problem we have with a gap in trust in science. I think it's on all of us to communicate clearly and transparently to try to turn that boat around, because that is really going to be an impediment for anything we try to do moving forward.
How can the pharma industry make sure that we are having healthcare basically for all, that just not the well-to-do are getting the treatment, whether it's on COVID or anything else?
I think one of the key things that the industry has been really focused on, that the COVID pandemic really shone a light on, was health inequities and what can happen when people are not able to access care, and data in particular that needs to reflect the broad scope of American experience when we're looking at healthcare interventions. And so one thing the industry can do is clinical trials. So we can increase the diversity and the representation in clinical trials. Our members have been very committed to this. We have clinical trials principles. We did a survey recently. Over 97% of our companies have concerted efforts to improve diversity. But we think more can be done, and we actually have some very exciting news that I'm going to put a teaser out for everyone that we'll be having some announcements coming soon on that.
Okay, pretty big news?
Yeah.
Okay, interesting. A lot of the discussion around healthcare now is very spirited. Sometimes it's nasty. But there have been, as we talked to Stephen Hahn earlier, there have been some bipartisan bills. Do you see, the 21st Century Cures Act, the Right to Try, FDA? Do you see that being essential moving forward with the future of healthcare in 5 to 10 years? We've seen the Obamacare/Affordable Care Act battles. They've gotten a bit tiresome. Do you think that there's some hope now, because at least part of the COVID response from Congress, not all, was bipartisan?
Yeah, I mean, I would hope that healthcare is one place where we could have bipartisan solutions. I think right now, Congress is considering the authorization of the user fee agreement, which includes some very important regulatory science enhancements and things that would help pave the way for some of our most advanced technologies, cell and gene therapies and other things. So that really needs to get done, and if it doesn't, we could see pink slips at the FDA sooner than we would like, which is really a bad situation. But I think the key thing is that we have to make sure that we're continuing to support the policy environment that makes the U.S. the leader in biopharmaceutical innovation. So we have a good policy environment right now. Last year, our companies invested over $102 billion in R&D. But Congress is also considering some less bipartisan proposals, such as reconciliation, which would have a pretty negative effect on our company's ability to continue to innovate.
And do you think, we're in a make or break time for the reconciliation. It expires on September 30th. Obviously, that would not need, as you mentioned, any bipartisan support. Do you think that is going to move forward right now? Obviously, it's something you don't want to see, but others are pushing for. So, this is a push and pull town.
Yeah, it's hard to say. I'm not going to weigh in on that because politics.
What about the future of innovation and how government handles that? Because we've had a couple speakers who said, there is, of course, a role for government, but let's not make it too big.
Yeah, to me, the biopharmaceutical research ecosystem, which includes the government's role with NIH, which is really important for beginning a lot of the research, and a really robust private sector working together, has been incredibly successful. We have a really good balance here, supported by policies like the Bio-Dole Act that facilitates the transfer of intellectual property from the government to the private sector. That's a really incredible policy framework and has led to, again, this unprecedented innovation. We are seeing now really transformative things coming through the pipeline. For example, we just did a report looking at blood disorders. There's over 500 plus blood disorder treatments in the pipeline, from cancers to sickle cell disease. Sickle cell disease is a disease that impacts 1 out of 365 Black Americans. And there are treatments coming through the pipeline that could completely change the outcome for those patients, could completely reduce the terrible pain and side effects and allow them to work and live a much longer, more productive life.
Last question. We're here at our first in-person event in more than 2+ years. We've been doing this virtually. It is great to see people back in person. But there's a certain COVID-19 fatigue, even though a number of our speakers, including me, vaccinated but still got COVID. How important is it for Congress and the administration to keep the focus on COVID-19? Obviously, there's a COVID-19, another package that is stalled, but some people kind of just want to move on, but this is not over.
It's not over, and I think as Dr. Fauci said, more could be coming. Pandemics are going to happen. We cannot take our eye off the ball. There are really important, critical public health threats that are still out there. CDC came out with a report last week that actually showed that during the COVID pandemic, hospitals were using a lot of antibiotics, about 80% in the early months, and that has driven drug resistance, superbug-resistant drug resistance up incredibly. So we're seeing now some of the pathogens that used to be treatable are now 80% resistant or more. So this is actually exacerbating another burgeoning public health crisis that could be even more detrimental than COVID if we let that go unchecked. And
that is a huge issue that doesn't get the attention it deserves. Well, Jocelyn Ulrich, thanks for joining us. Please thank Jocelyn for joining us this morning.
Thank you.
Joining us virtually is Dr. Bartley Griffith, a pioneering surgeon and professor of surgery at the University of Maryland School of Medicine. He'll be talking with Steve Clemens, contributing editor of The Hill.
Let's see. Hello, Dr. Griffith. It's great to be with you. We've got a room full of people who want to hear essentially about where innovation in your space, and to remind the audience, you have the unique distinction of being the first person, as I understand it, I'm going to get the terminology wrong, xenotransplant, non-human hearts into humans, in this case a pig, and this gentleman that you did this for lived an extra 2 months, and I think right now as we're discussing, what the critical points in science, in innovation, in health, and what's coming down the pike, you're sort of one of the pioneers in that. Where are we going?
Well, it's a good question. Most of us who toil, from the laboratory, taking in advances into the clinics, never really know where we're going until we test things. And our experience with the pig to human transplant really was declared a success in spite of the fact that our patient only lived 60 days. It was the first example of a genetically engineered organ, that could support life in a human, in spite of more than 10 years of work in non-human primates, which got us to a point of equipoise where we could propose an emergency use to the FDA. And the FDA treats these bioengineered, if you wish, genetically altered animal organs as drugs. So it's considered a drug. So if you want to use it like an experimental drug, say for COVID or anything else, you need to go through a drug portfolio of regulations. So we had an emergency use for this patient who was desperate and had no other opportunity for life. And what we learned was it worked. There are going to be a lot of things that proof of principle, we'll have to get back to, making better. But just like the Wright's airplane that only, flew 90 yards or something, for our first flight, I think, in spite of losing our patient, we learned a lot, and the patient was so sick. I think it was his illness more than anything else that did him in the end, not the organ. The organ never rejected, we believe.
So this patient, you were able to proceed because of a compassionate use authorization, because every other avenue this individual had was turned down or not possible for that individual. I guess my question in the FDA is the FDA friend or foe to you?
It's been very friendly to me personally as an investigator who applied over the Christmas, New Year's holiday for permission to treat this patient. They worked tirelessly along with our team to get it right so that this patient had an opportunity. The regulatory hurdles are significant, and in many ways they should be. This is an important next step. We got to get it right, and a misstep would probably do the field a lot more harm than the initial sensationalization commercialization of the event. So I'm all in to the FDA, and I think if we do our job right, they have already demonstrated that they understand compassion and need, and the need for more organs. There are many thousand patients under kidney transplantation who need kidney transplantation on dialysis, something like 600,000. And so we've got to get that number way down, right? Going forward, 600,000 with severe end-stage kidney disease. And, there just aren't enough organs. And so the idea would be nobody thinks twice about once they get a hip replacement approved that they can go in and there'll be an artificial structural hip for them. Why not for hearts, lungs, livers, kidneys, and pancreases? It would be a huge healthcare burden alleviator.
I can tell, Doctor, that you are operating within the scaffolding and on the stage and in the parameters of, ethical and regulated treatments that you're trying to innovate. And I guess we have not coordinated on this question, so he may storm off stage. But what is the state of ethics in the world of bioengineering? I've interviewed, the people who created CRISPR before and others, and we saw in China misapplication there. We have a lot, when we talk about science, and we have a lot of focus on U.S. healthcare here, but there's a global medical scene out there. To what degree are you concerned that we've got some wobbliness in the ethics and bioengineering world?
Well, I am concerned. I've been a medical innovator for a long time, one of the first people to use an artificial heart, and that created a biostorm as well, and I think that in the end, the biggest issue is patient consent, right? That the patient understands that this is an option and it's experiment. Once you get past that, the ethics of genetically engineering an animal organ, that's an issue that I think we can deal with fairly easily. Choosing the pig as a animal of choice, we hate to maybe take a life of any kind to save a human life, but if you're going to assume that someone's going to have to die for a heart to be replaced, human or animal, of the animal kingdom, pigs are those that maybe would be most easily understood. We would stay away from baboons, we'd stay away from chimpanzees, which would be easier to make a match for. But they're too close to us, and we wouldn't even imagine that. Animal rights advocates have been strong, and there have been a number of criticisms of what we did. And I understand that perspective, but the pig is easily raised, and they reproduce quickly and they grow fast. So if you're going to convert this into something useful from a commercial perspective, you have to have something like a pig in terms of a product.
In the health innovation space, it occurs to me that you're in the University of Maryland. One of the areas we've been talking about as part of that ecosystem has been our deficits in diversity and inclusion, the health outcomes. But I'm just interested, as you look around the room, about who the surgeons are, who the patients are, who the students are that are learning from you. What's the scene like, and is it different than it was 10 years ago?
Oh, it's a lot different. As a cardiothoracic surgeon, it was a field of mostly males, mostly white males, and very rarely were there women involved in that field. Consistent with the change in our entry of women into medical school, which now predominate over men, actually, in most medical schools, by a little bit, maybe a few percentage points more women. We have found that there doesn't seem to be a gender predilection for heart surgery per se, and some of our best candidates for residency and our best residents now are women. Diversity is a problem in medicine for lots of reasons, and I think that our medical schools are working hard to adjust for that purposes, like all great institutions of education.
Right.
It's a crisis, and we need to work for it. I'm proud of the progress that's being made, and our graduates who are going into all fields of medicine are diverse, more so than ever, and the data would suggest we're getting there. Dr.
Griffith, let me finish with a fun question. Some years ago, I think it was about 15 years ago, I had cool dinner in the Bay Area in San Francisco with some of the founders of Google and Oracle, and our chairman at New America was there, Eric Schmidt, and the topic of the dinner was how to end death, that we would one day have the technical and scientific and methodological capacity to efficiently end death. We had a couple of DC types in the room who then said, it's going to be terrible for entitlements. But I guess my question to you is, you look at the frontier of science that you're at, is that a ridiculous presumption? Are we getting to a point where we will be able to at least extend life so significantly that it creates a very fundamental shift in the social contract in this country and around the world?
Well, I think we're going to get older. Whether we're going to perpetuate life, I think we'll extend life for sure. And I think in the lifetime of my grandchildren, we would see a life expectation, go up by 10, 15%, which is huge. And I think there are lots of reasons for that. If we start thinking a little bit beyond that, you have to define life. And
Right.
Is life just your brain? And, the body may wear out, and maybe you'll be transferring brain, if you wish, onto a younger pedestal, which could be bioengineered. So, yeah, let's go Star Trek and think big. But we've got a lot of problems to worry about, and I don't know that extending life should be the proof of principle
Right.
of our great medical advances. We got to take care of the good people we have, and I see a lot of people dying prematurely from all sorts of reasons.
Right.
And it starts with accident prevention, addiction, and then natural processes of cancer and heart failure.
Final, do you have other patients lined up or out there that could benefit from what you achieved with this zero patient, this first patient that you had with the big heart?
Great question. Short answer, yes. But we're not ready to pull that trigger and ask for one until we have exhausted all that we could learn from our first patient, Dave Bennett. We're just about there. So hopefully we'll gather up our summary of that and then find a patient in need. People have written to us, of course, and the average patient with cancer can't be transplanted. So
Right.
We have an avenue for patients that have no option in that regard. So I think we'll find better candidates. Dave was really sick, and I think one thing we've learned is having been successful for 60 days, the principle is there. So our next patient doesn't have to be on that real.
Well, ladies and gentlemen, this is a real biomedical pioneer, Dr. Bartley Griffith, professor of surgery at the University of Maryland School of Medicine. Really appreciate it. This was a lot more fun than I thought it was going to be, so thank you.
Okay. Thank you. Bye.
Okay.
Please welcome to the stage Chiquita Brooks LaShore, the administrator of the Centers for Medicare and Medicaid Services.
Of this, it's really cool.
I heard just
You know?
the end. I heard Star Trek, and my ears perked up because I'm definitely a fan.
If it weren't sort of morbid, I'd love to let him have a chance at me at some point, But anyway, that aside, look, I know you have one of the best jobs in health, most important jobs in health, and one of the worst. And everyone looks at CMS for answers and rules and making everything fair, reimbursability, paying for these things. And I know that one of the biggest objectives you have right now is to address equity and to address access and to even out that opportunity. And I guess my starting unfair question is, how do you make the world out there believe that you're serious?
So it is the best job. And I honestly feel so privileged to be in this role. And at this time, I've been thinking a lot about just the era we live in, right? And I think that COVID-19 has exposed what it means to us as a country to have inequities. And I think there is a different level of dialogue. That is a moment in time, and it's a brief moment. But But I think there's just a different awareness. And as you probably know, I was in the Obama administration. The Affordable Care Act is where, my heart is. We did not use the words health equity during that time. People didn't talk about it. And now that is so much at the forefront of everyone that comes to talk to me. And so I think the way we take this moment and make it meaningful to last beyond my tenure is by making sure in every decision we are thinking about what are the impacts on the people who are underserved, as well as the providers that provide care for the underserved. And that's a piece that I think is really important in this discussion, because I think as so many people see an opportunity, and I don't mean that in a negative way, but I think a lot of the industry has embraced this idea of health equity. We want to make sure the actual people that care for people who are underserved are really part of this conversation.
Right.
And so by that I mean the community organizations, I call sort of them health adjacent, where they are often the ones that connect people to care, the FQHCs, the providers that really serve the underserved, to make sure as we think about our Medicare payment policies, as we try to enroll people, that they are really a part of this conversation.
Right, and so one of the questions I have, and I'm a layperson, so I just pretend to be a health policy wonk, but I get a lot wrong, so if I frame this wrong, please correct me. And I think one of the big issues is, when the Affordable Care Act came in, as I understood it, the big transition was to move to a model of wellness and away from fee-for-service within the healthcare system. And while I know that that's not necessarily CMS land, I am interested in how CMS land and the Medicare Medicaid program look at wellness, or whether their contractors and providers are still operating in a fee-for-service world, because you've been elevating mental health, and mental health is always this thing out there that I think is so important, but in a lot of American health providers have a hard time laying out the economic foundation for robust mental health services. So I know that's a long way around of saying, how do you deal with the wellness orientation within the world that you have control of gravity, and where is mental health in that?
So I would say we are very much a part of this conversation about how do we move away from just treating acute catastrophic events. And when you think about the population that we serve, we now have over 150 million people that are covered by our
catastrophic
programs.
Events are us.
Yes, I mean, we and mental health is a core part of certainly of care, but really the people that we care for. So when you think about the crisis in this country on mental health, it's particularly in our elderly, people who are in nursing homes, and on the other end, kids. And Medicaid and CHIP cover a lot of the children in this country. And so I would say a couple of things. We're really thinking about, in our Innovation Center, CMMI, how we can develop models that really encourage more holistic care, certainly through our health plans, whether it's in Medicare, whether it's in ACA marketplace coverage, whether it's in Medicaid, really trying to make sure there is more of a holistic perspective. And that's one of the things we are really focused on, making about the person and less about a particular model for providers, and really trying to make sure that we are keeping people at the center of it. And then to focus on mental health, this is a place where we are trying hard to work with other partners. So certainly the other parts of HHS, like SAMHSA, like HRSA. I spend a lot of time with my colleagues there, really thinking about, at the state level, how can we coordinate care better? Because you do have grant programs that serve mental health services that could be better coordinated, say with the Medicaid program, and then continuing within our own program authorities. So telehealth for mental health services is something that in Medicare we've just extended permanently. Medicare does cover a lot of mental health services in this country, and we're trying to use our authority in the ways that we can to try to better integrate.
You know, I've been looking a lot at America's broadband picture and who's not digitally connected, and you go out and take a look at that, and we've done some geospatial mapping of that, and you kind of overlay that with, you know, health outcomes and performance, and you look at the rural-urban divide, or you look at information deserts or food deserts inside cities. Guess what? They're health deserts too.
Yeah.
So a lot of these problems that you're wrestling with are systemic, and other of your partners in government are wrestling with them too.
Yes.
Can't you all get together and just fix it?
Well, we do spend a lot of energy trying to coordinate, and these programs have different congressional authority, and sometimes we have the ability to make these changes. Sometimes we're going to need congressional perspective, but we are trying as hard as we can to coordinate where we can. And you are absolutely right. We've seen our colleagues at Age of Justice did a study on telehealth and found, yes, in some areas, great. In other areas, Black and Latino people are using, have less access to video, and in rural areas where we need it the most, we're not seeing as much as the telehealth.
So what is happening? Look, and again, as a layperson, what I understand is that the reimbursability of telehealth during COVID was sound, and we may be getting wobbly today. Is that, I don't know if that's a fair assessment, but why are we getting wobbly, and is it CMS's fault?
It is not CMS's fault. CMS has limited authority, and so where we have used our authority is we can make mental health services permanent, telehealth. Congress has extended telehealth beyond the public health emergency for 5 months, and that's something we need Congress to do. So while we're in
after that 5 months expires, a lot of services that people have grown used to in telehealth may be ones that are no longer paid for.
That's right, and we do not have. We are.
Isn't that going to be like a tsunami hitting the health system?
We are concerned. And
how concerned? DEFCON level?
So my biggest concern is around the unwinding, around the public health emergency of coverage. And Medicaid, we are at record levels of people enrolled in Medicaid and CHIP and marketplace coverage. And because of the public health emergency, people have been on the Medicaid program without what we call redeterminations. And that is a process that often loses people. And it is imperative on all of us across all stakeholders to really focus on this. We are working with states to try to make sure that we hold on to coverage. But coverage is not, I like to say, necessary, not sufficient, right, for making sure that people have access to care. And the difference in people not having care is what I would say we are most concerned about with the public health emergency.
I ask this respectfully, and I don't know, do your colleagues at CMS, are they doing all that can be done around drug price negotiation, around, thinking about, costs of care, thinking about how science is transforming methodologies and creating new opportunities that I hear sometimes do not fit within the Medicaid parameters? Should we be putting more pressure on your colleagues to find ways to work with the innovation sector, or to work with things to both address, I guess the big tensions I feel out there, and we have the pharma folks up here, are between grabbing science, delivering more opportunities, but making sure it's more equitably shared and distributed at a cost that makes sense for the country. Do you know what I'm saying?
I know what you're saying.
And I'm not putting this on you,
right,
but you run a huge organization that's out there.
Yeah.
And so what should we as taxpayers and citizens be expecting on that front?
This is something that we are absolutely trying to address, in making sure that people are getting access to the innovative products that are coming on the market, which are exciting. I would say a couple of things, and then of course people always want to put pressure on us, which we welcome. That's
how much do you welcome?
I would say on devices in particular, that's a place where we, CMS, have been working with the FDA for really 20 years to try to streamline the process. We had a number of discussions, stakeholder open discussions over the last couple of months, and that is an area where we have said by the end of this year that we're going to put out rulemaking to really try to streamline that process of these emerging devices, and it's really an area of attention and focus. That's really around the Medicare program. I think also I encourage people to really look to the states. There are so many things that are coming that really serve a younger population. And it's not always the Medicare's focus to cover some of these innovative products. Let's just say, innovations that really affect births, right, or children, really making sure that we are engaging, that industry is engaging with states who make a lot of these decisions and with private payers who in the marketplace have a lot of flexibility. So that's the other piece that I would say, that sometimes I think people come to the government, and not that we shouldn't be absolutely incorporating this, but we're not the only game in town. Even in our programs, there are actually other entities that are a part of this conversation that need to be engaged.
I'm interested in show and tell in the sense that whether or not you've been able to identify a rural area, a Native American area, a community that has traditionally been left out of the health outcome opportunities of, Beverly Hills or something, and so when you look at that, if someone's been able to kind of change their stars a bit and figure it out, and whether or not you've been able to kind of find some of those stories and share them and learn from them, are they out there or are they really elusive?
They are out there. I've been doing more traveling as of the last couple of months, and was in Cleveland, Ohio, visiting just this organization that I was so excited about. They're very focused on maternal and infant health, and really seeing the city officials, all of the stakeholders around a room.
I mean, not to interrupt, but our maternal mortality rates are insanely bad.
They are
right?
horrible.
Yeah.
And, the vice president has made this a priority. We are she and I personally have been very engaged.
What does
across
it
the
mean that
country.
she's made it a priority? What can she do?
Absolutely. So just to start, in December, she pulled together a White House discussion. And I think people were I spoke with stakeholders the day after, and people were so moved that maternal mortality was actually getting this level of attention. And women actually telling these terrible stories about everything being fine as their daughter was delivering, and then a couple of hours later they hear their daughter is dead because of hemorrhaging that wasn't controlled for. So she has made this a whole of government approach, pulled together a maternal health cabinet where all of us are on the hook for producing initiatives. We at CMS obviously have a big role in this. So some of the things we've been doing.
Are you able to write about this, show this, and say, hey,
Yes.
folks, here's some best and promising methods?
That's right. So we've been announcing these maternal health blueprints. More information will be coming out very shortly from us, CMS, about the work we're doing. We've been working with states on postpartum coverage, which is one of the key, not only, but a key issue. I, as a mother, say, like 2 months after you give birth, the last thing you're trying to figure out is switching health insurance. Well, millions of people have to do that.
Right.
And so we're seeing states who are expanding coverage through the 12-month postpartum period, which is a huge game changer in terms of making sure that women, that babies actually go to the doctor.
I asked somebody earlier this morning what was the most important thing I could talk to you about, and they gave me the worst, most boring topic, and I've avoided it until now, and we have 36 seconds. But they said payments reform.
Yes.
Is like, my eyes glaze over when I hear it, but I know it's a huge issue in your world. Why is it a huge issue? Why is it so boring to all of us, and why should it matter in a big way? I mean, I just want you to turn us on with some answer on payments and tell us why it's such a big deal.
I love that you asked this question and then you said how boring it is, because I say the same thing to the team. Nobody wants to hear we're going to change the payment rates for providers and make them do blah, blah, blah. What people want to hear is how it is going to change care. And so what I would say is what we are focused on is trying to make sure that our payment policies give incentives for people to have more holistic care. And that's what we're focused on. The way our traditional fee-for-service statute is written, it doesn't always do that. And so we are trying to make sure that our payment reforms really give incentives to a whole range of providers to provide more holistic care, back to your point about mental health, that primary care, that some of these special supports, dementia, making sure caregivers are cared for, that we actually give incentives for people to provide those services, not just you come to the doctor and get your blood pressure checked.
I appreciate it, and I'm still awake. So thank you for that answer. Chiquita Brooks-LeSueur, Administrator of the Centers for Medicare and Medicaid Services, thank you so much. Really appreciate it. Thank you.
Thank you.
Our next panel of guests will discuss quality care for our most vulnerable. Please welcome Jack Hoadley, Research Professor Emeritus at the McCourt School of Public Policy, Georgetown University, and Dr. Mark McClellan, former CMS Administrator and the Director of Duke Margolis Center for Health Policy. They are joined by the Hill's Julia Manchester.
Thank you so much to you both for joining today. You know, Dr. Hoadley, I'd love to start with you in understanding the progress of Medicare in the nearly 60 years since it's been around. I mean, when it was created, nearly half of Americans 65 and older were uninsured, and more than half paid for health care out of pocket. So, you know, nearly 60 years later, where do we stand?
Well, it's really one of our big successes in the healthcare sphere. I mean, as you point out, you know, back before there was Medicare, a lot of people really were struggling to find how to get care. They didn't have coverage, and without coverage, you don't have access to services. And now, you know, it's not perfect, but Medicare really does guarantee that nearly everybody who's over 65, as well as those with disabilities and certain other conditions, have access to health insurance that really does provide them access to the care they need.
Mm-hmm. And, you know, Dr. McClellan, you're the former CMS administrator. How have the needs of Medicare demographics evolved? I mean, in 2022, what should the agency be focused on?
Well, you heard a lot about that from Chiquita just in the last session. So this is, I totally agree with Jack, this is an extremely important program, not only for some of the most vulnerable Americans with the greatest and most complex health needs, but also it's now big enough with our, you said, our shift in demographics. So many people covered by Medicare and Medicaid that has an impact on our overall healthcare system. So it shapes what happens everywhere else. And with the changes that have come, with people living longer, with more biomedical progress, you've talked about that all morning, Medicare's benefits and Medicaid benefits do have a challenge in keeping up. I was there at CMS when we implemented prescription drug benefit. That was passed in legislation in 2003, you know, decades after drug coverage was part of many other insurance programs. And it's something that Congress is still thinking about now, because we need to make sure that it keeps up to date with the changes in medical technology, which are now moving more in the direction of more complex biologic products, specialized treatments like gene and cell therapies, early diagnostic technologies, and these were not the way that medicine was practiced back in 1965. That was about treating an illness and treating a problem with a body part or an illness after it's progressed in the hospital. Now, and for the future, it is increasingly about identifying people at risk early and intervening with treatments that can intercept, if not cure, the progression of an illness early. And that's a redo for the way Medicare is set up, and I don't think we're all the way there on keeping up with that.
Right. And Dr. Hoadley, to that point on Congress, I mean, where does the discussion on this currently stand in Congress when it comes to prescription drug coverage? I mean, I'm on the campaign trail quite a bit. I hear a lot of congressional candidates talking quite a bit about this, and it seems like that's something there's a bipartisan push for. I mean, what can we expect to see?
Well, there is, you know, this is an important area, and as Mark says, the drug benefit in Medicare is relatively new, but it has some issues that have arisen. So one of those is the fact that there's no out-of-pocket limit. That's something where there's bipartisan agreement that there ought to be an out-of-pocket limit. So if you happen to be taking one of these very costly drugs, you reach what's in Part D world called the catastrophic phase. Now, in most healthcare worlds, catastrophic coverage means you stop paying out of pocket. In Medicare, you don't. And so there's a proposal as part of the current legislative package to cap out-of-pocket costs and set an absolute limit. And while both parties may not agree on exactly how to get there, they do agree on that principle. There's other parts that there's more disagreement on, which is how do you tackle the pricing of these very important new drugs. And we have drugs now that cost tens of thousands of dollars, if not hundreds of thousands of dollars for a year's use. And the part of the discussion, at least in the Democratic proposal that's before Congress, is how to start the process of having some greater government role in negotiating the prices of those drugs. And so maybe that will emerge from this year's package and the reconciliation bill, maybe it won't. But trying to figure out how we get a handle on drug pricing is really one of the challenges that we have.
Right, right. And I mean, I just want to make a note before we continue. Karen Jones, who is the president and CEO of the National Caucus and Center on Black Aging, unfortunately couldn't be here with us today, but I would love to chat with you both about, sort of what we were going to chat with her about as well. I mean, she focuses on how this is impacting the Black community in general. I mean, Mark, I'll start with you. How is this impacting minority communities in terms of, the prescription drug benefits?
Well, those out-of-pocket costs for seniors and people with disabilities with high healthcare needs unquestionably is having a big impact on access for seniors. And when we designed the benefit in 2004, it was a different era. There weren't as many of these specialized drugs. We weren't even sure if drug coverage would actually work. And so what we ended up with was a benefit that didn't provide very broad coverage or an out-of-pocket limit at the high end, and one where the government is actually picking up 80% of the cost of those drugs. Now, that's not a good recipe for either protecting seniors or encouraging strong negotiation to keep costs down. And Jack's right that there are some differences of opinion about how exactly the Medicare drug benefit should be modified, but I think there is actually fairly strong, at least by today's standard, bipartisan support for modernizing it to include an out-of-pocket limit, to shift more of the accountability for costs in that high end of the benefit, and also in what's left of the so-called donut hole or coverage gap, shift more of that to health plans who should be on the hook for negotiating lower prices, and to drug companies to some extent too. So that piece of the legislation I think would be really helpful for people like those with limited incomes who are struggling with drug costs today. The others, I think, more controversial. I think there are probably better ways to try to bring prices down. The negotiation, such as it's called, provisions in the legislation now are not an approach that any other country on the planet is taking to try to negotiate prices. Those efforts really do try to focus on value and are we getting the drugs that make the most difference to the people who need them. This is really setting a regulated price that would be kind of lower for Medicare than everybody else. So that's not good for price negotiation in the ACA exchange plans or the commercial plans that also are really important to people with limited means today.
Right, but there is, hope for the future, I mean, with the legislation. I mean, I guess I'm curious, coming from the political side of this, how much is that politics hindering this? Because it seems to be a bipartisan issue, but when you get into the nuts and bolts, and I'll pose this to both of you, I mean, it seems like that's where some of the issues lie.
Yeah, it is. I mean, and this is where, the nature of the way debates have evolved in Washington has changed, because, when I first came to Washington a long time ago, there was a lot more there would be the big debates that were partisan and were disagreements over, some of the higher level issues. But the Congress would sit down and figure out the more technical things that there was agreement on, and you get those done. So right now we're in a situation where the parts of prescription drug reform in Medicare, and of course I could take this to other issues as well, but that's the one we're on at the moment. There's a big set of issues on which there's bipartisan agreement. There have been, the last Congress, the previous 2 years, there was an agreement I think on the Senate side, on a package that, agreed across parties. But it fell down because there was a different version in the House and they never could get to the agreement. We don't see the process of sitting down and figuring out a way to carve out the things that they do agree on, get those passed, continue to have the debate, and maybe somebody prevails on the more controversial things. But we don't get those other things done. And, we're talking here about drug issues. There are issues with the broader part of Medicare. You asked the question about, minority beneficiaries. Another big barrier to those with limited resources is the lack of an out-of-pocket limit on Medicare as a whole. So we have some very large cost sharing in the Medicare program, not the way we would probably design a program today. We have 20% coinsurance for any kind of physician services. We have a very large first day deductible when you have a hospital stay. People solve that if they're low income by being on Medicaid. Some people solve it by going to a Medicare Advantage plan, others by supplemental coverage. But we still have a small segment of the population who has none of those and faces those high out-of-pocket costs. So again, we could redesign, I think probably without a lot of partisan controversy, the core Medicare benefit to make it suit the needs of people better. But of course, that would then run into bigger level debates about other parts of Medicare in which there's not agreement. But if we could really focus in on some of those things where there is agreement across party lines, we could probably make this benefit a more modern benefit that suits the needs of today rather than the way it was designed in the 1960s.
Yeah, it made me think back to when we were passing the Medicare Modernization Act, and that involved discussions with, I was in the Bush administration at the time, so obviously a lot of Republicans, but also Senator Max Baucus, Senator Ted Kennedy ended up not supporting the full bill in the end, but was very helpful in getting to crafting a package that could work, and less of that is happening now. Instead, I think you're seeing more of that happen, especially for vulnerable and underserved populations in the states, where there is a lot of interesting work going on around trying to integrate Medicare and Medicaid benefits better. So for the lowest income beneficiaries, they do get more comprehensive help with Medicare costs and Medicaid wrapping around, but often those programs are fragmented and you get the results like you heard about from Chiquita, where we're just not delivering integrated care to patients that could prevent everything from maternal health problems to people being able to live at home and do better with their serious chronic illnesses or Alzheimer's disease. And then you also see steps like this happen, and that's by the way happening in blue and red and purple states. It's not as partisan. And you also see that happening in the efforts that the administration is undertaking using its regulatory or administrative authorities, like, as Chiquita alluded to as well, the ACO REACH program, which is really an effort to channel more resources and more intentionality into actually helping the providers for people who typically have less access to care put together the kinds of services that those individuals really need to navigate in the healthcare system and stay well. It's incredibly hard today for people with middle-class resources. It's even harder for people with health problems and worried about where their next meal is coming from or housing problems. But there are good examples of how to address that. And I really want to commend the administration for trying to take that on in the absence of more comprehensive legislative solutions.
Right, and I want to go back to your point about what's happening in the states. So you're saying that a more federal action versus the patchwork of what you see happening at the states would be more effective.
Well, it is a patchwork at the state level, and to Jack's point, if there were steps, some good ideas out there with bipartisan support for how you can make it easier to integrate Medicare and Medicaid benefits or to update the Medicare benefit package. If you think about some of the technologies that have been discussed today, Medicare benefits just don't do it. It takes an act of Congress to cover a preventive service. So what are we going to do with all of these, multi-cancer detection tests that are coming along, and all these other genomic or proteomic-based tests that can really help identify patients who are at risk. And Medicare is very good at covering the downstream problems, but has been less good at providing coverage for the social determinants, the social factors that have such a big influence on whether people are able to take their medications. It's not good enough to just provide drug coverage and low out-of-pocket costs for drugs if you can't focus on, how am I going to adhere to my medication this week because of housing issues or threats at home or other things like that. And as Chiquita said, there are a lot of good examples coming from states and coming from local initiatives supported by things like the Medicare ACO program to try to address this, but they're not as systematic as they could be. And that's where it seems like there is some potential for more bipartisan action. Everybody, I think, fundamentally agrees that healthcare should be increasingly about accountability for getting results for patients, for actually improving health. And I hope we can find ways to get there.
Right. And I'm curious, just as a layperson, someone who doesn't work in the field of healthcare at all, we're year 2 of this pandemic. How has COVID-19 impacted Medicare, or has it had not as big of an impact because I guess they're not directly linked, or maybe they are? I'll pose that to both of you. Yeah.
Well, if you don't mind, this is my first talk with my CMS staff when I became administrator was telling them, you were the nation's largest public health agency. And I got pulled aside by my staff after saying, you're not at FDA anymore. It's the FDA before. This is not under the Public Health Service Act. This is under the Social Security Act. It's about paying for health care. But how we pay is so important. And if you look at what's happened in the pandemic, it's been disastrous in so many respects. Slow access to testing, and even when we had tests and treatments available, really uneven and inequitable access, especially early on, leading to big health disparities. But if you look at the things that CMS did in the previous administration and this one, rapid introduction of lots of flexibilities in how to pay for care, new steps to provide additional payments to physicians and labs that were quickly diagnosing patients and sharing that information to help with local response and to help those patients get better outcomes. And under these, back to the boring topic of alternative payments, these alternative payment models, those primary care groups and health systems didn't have that big trough in their payments. They had stability in payments, so they were able to build on the steps they're already taking around home-based care and telehealth and services like that. I think when we look back historically, we're going to see that the steps that CMS took were probably pretty fundamental to our healthcare system being able to adapt and move out into the community and take more steps to help contain the pandemic. All of that said, we still have a long way to go, and I don't think we've yet learned the lessons from COVID, either on the public health side or what it should mean for the way that we pay for drugs, pay for vaccines, deliver health care.
Right, and Dr. Hoadley, would love to get your take on that.
Yeah, I agree with what Mark's talking about. I would bring up another area that's maybe not got such a happy story, which is our nursing homes. And I think COVID really helped to shine a light on some of the shortcomings of what's happening in our nursing homes. They weren't very quick on their feet to adapt. Even things like getting vaccines out, there were ultimately some good ideas out there about how to make sure people in the nursing homes got their vaccines, and it was partnering with some of the drugstore chains to get them out there in the nursing homes. But I did some interviews at the time, and it worked some places and it didn't work so well other places. And of course, there was the overall issue of reluctance to vaccinate in so much of the population that affected staffs in the nursing homes. And so we had that sort of going on. That's probably not something you can put on the Medicare program for blame. But Medicare is one of the funders, along with Medicaid, of most care that's in nursing homes. And so, I think there's room to try to go in and learn, what were the mistakes made, what were the successes, and how do we do a better job of maintaining care in nursing homes. It's not one of the areas we do well. whether we're talking about skilled nursing that comes after you have a hospital stay, or more of the long-term care for people who just can't live in their homes anymore. So I think that's an area where there's a potential for some examination and trying to see how we can do better in the future. Not just for a COVID-type situation, but more generally.
Absolutely, absolutely. And we only have 30 seconds left or so, so I think we'll leave it there. Thank you so much to you both for joining me today. It's been such an informative discussion, and a discussion, I mean, gosh, we'll be having on the campaign trail going forward. So thank you so much, Dr. McClellan and Dr. Hopefully. Thank you.
Thanks. Great to be with you all.
Thank you.
And now, a message from our sponsor, Protect the Promise.
Along with inflation and other economic pressures, healthcare costs are rising across the country. When out-of-pocket costs become too high, everyone loses, particularly the millions of Americans living on fixed incomes. That's why Protect the Promise advocates for lawmakers to pursue policies that lower out-of-pocket costs for medications that seniors and people living with disabilities and chronic conditions depend on for treatment, like diabetes, heart failure, and strokes. Pursuing sensible solutions will lower the overall costs for the healthcare system and ensure its long-term sustainability, all while putting money back in the pockets of vulnerable Americans. Such policies should prioritize lowering barriers to access and ensuring that people can get the medications they need without risking financial uncertainty or peace of mind. As Congress looks for a path forward during difficult economic times, the health and well-being of our seniors must be a top priority. Lawmakers have a responsibility to work towards common sense, bipartisan solutions that address affordability and access concerns, while strengthening America's safety net for future generations. To learn more and get involved, visit protectthepromise.org.
Our final guest is Dr. Ashish Jha, the White House's Coronavirus Response Coordinator. He'll be in conversation with Steve Clemons, contributing editor of The Hill.
Dr. Jha, thank you so much.
Good morning. Thanks for having me here.
We're always interested in, the Coronavirus Response Coordinator is not exactly a position that lots of rosaries and triumphs are shared. So you came to do this in the administration. Are you having a good time?
Am I having a good time? It's intense. It's a huge privilege. I feel like we're having real impact.
Where are you having impact?
Well, I think we're making big impacts on availability of treatments. So I'll give you an example. I came into this job just over 3 months ago. At that point, Paxlovid, which I think is just a fantastic, the data on this is very clear. We were prescribing as a country about 4,000 or 5,000 prescriptions a day.
Wow.
We're now at about 35,000 a day in 3 months. I think we have made Paxlovid widely available, easily accessible. These are the things that you can do. When we decide we got to make treatments easier for people to get, we just have a bunch of levers we can pull to drive that. And I think,
So are we at a wall? We had Anthony Fauci up here. So 67% of the American public's been vaccinated. About half those have been boosted, which overall is not a great picture, according to him. I interviewed former Mayor Eric Garcetti of Los Angeles, or maybe he's still mayor. Eric Garcetti, whoever he may be now.
Soon to be
But he
ambassador.
said something really cool when there was vaccine shortages, and people like myself were figuring out how to get in one of the categories to get this, as we were kind of all dealing with it. He said that there were, throughout the city of Los Angeles, they had vaccine party nights, so that people sent their surplus that wasn't used that day to these places at midnight. They had music, they had drinks, and probably lemonade or whatever, and they were able to use it. I thought it was one of the most innovative ways to help
broadness, I didn't see a lot of pickup of that model around the country. Are there things that we're not doing as we sit in Washington and say, okay, we've got to find seductive or interesting or dynamic ways to encourage people to get vaccinated? Are we doing those things?
Yeah, it's a great question. So I think the strategies you use to not waste doses in the early days when demand way outstrips supply is different than where we are now, right? Where there's plenty of supply.
Yeah.
And it's interesting, it's easy to say the demand isn't there. I don't even think that's quite right. I think certainly that kind of demand that we saw in January, February, March of 2021 is not there, but there's still plenty of people who say they're willing to get vaccinated. The ground game now is about making it easier for people, making it accessible. So mobile vans that deliver vaccines, not quite as sexy as parties with drinks. But probably more effective for where we are in terms of people who are not getting it. We're seeing cities do that. We're working with cities and states to try to make that available. And by the way, that model doesn't just work for vaccines, it also works for treatments. So we have been, New York City, for instance, just launched this, what I think is a fabulous program. It's a mobile test and treat site. You take a mobile van, it's got tests, it's got treatments, you send them into communities where there isn't big uptake of either testing or treatments, and you make it super easy for people. You really literally go meet people where they are. I think those kinds of things are happening. And of course, our job in government is to support that, to enable that, to get the word out about those things, help more cities and states do those kinds of things.
A big ferocious river that has run through this morning's conversations is that America's health outcomes are inequitable, that we do not have equity built in. There's a lot of reasons: systemic racism, divisions, tradition, et cetera. And as I get to some of the realities of COVID and who it impacted, part of it you can look at as sort of, the bias of the healthcare system. Part of it is an absence of trust between certain communities in that healthcare system. Both the Trump and Biden administration spent a lot of money on trusted ambassadors, folks coming in that they would be there. What is the status of that? I mean, did that work? Did it fail? Is it still going on?
The status of the equity enterprise?
Well, the equity challenge, but also having people see folks they trust that go into communities. With all due respect to Dr. Fauci, whom I happen to trust, not everybody trusts Dr. Fauci. So, how do you deal with that?
Yeah, even Dr. Fauci, no one is trusted by everybody, right? And so we need different voices for different people in different communities. Look, when the president came in 18 months ago, it was already clear that this pandemic was having a very disparate impact on different communities, right? I often say we're all in this together, but we're not all in this together the same, right? And we're not all in this together equally. So we see these very disparate impacts. And the president made a commitment, and I'm going to actually get to, did it actually work, to your question. Major focus on a health equity task force, major focus on community health centers. Remember those mass vaccination sites that we were set up?
Arenas.
There was a criteria in there. It had to be in a community that was socially vulnerable. Like that was a feature of the response. And what that meant was that in January, February, March of 2020, you saw initially this gap in vaccinations between white Americans and African Americans and Latinos. And by April, May, that gap had closed. On boosters, which again, not enough people are boosted, but initially as boosters rolled out, a little gap opened up. That gap has closed, and right now booster rates are the same for different ethnic and racial groups. Vaccination rates are the same. That stuff doesn't happen accidentally, right? It's deliberate. And so if the question is that an effort that's still ongoing? Absolutely. Is it making a difference? I can tell you all the stuff we're doing, but at the end of the day, you got to judge us by outcomes. And the outcomes are we're getting equitable levels of vaccinations, boosting. Last but not least, I just told you we've had this massive rollout of therapeutics. So what do we do? As those are going up, the question I ask the team, are we doing this equitably? Great that lots more Americans are getting treated. Are all Americans getting access to treatments in the same way? The answer, not as equitable as we need it to. We're starting to see a gap open up in communities that are more socially vulnerable with lower rates of Paxlovid. So unacceptable. So now we are going back, looking at the data, trying to figure out what else do we need to be doing. We just opened up pharmacists being able to prescribe. We think that's an important equity play in giving more people access. We're doing a whole series of other things. And my point is, don't judge us just by those actions. Judge us by, bring me back in 3 months and make me show you that we actually close those gaps. That's what matters.
One of the things that happened is Operation Warp Speed helped produce in a remarkable short period of time, based on historical models, vaccine alternatives to approach this. And then that box got checked off. Should we have called it Operation Marathon instead and have kept it going? Do we have, Tony Fauci this morning said, we need new vaccines.
Yep.
And so did we make a mistake of thinking we're done, we solved it, we got the vaccines, it's now just a burden of people getting them, as opposed to continuing the science and development?
It's a great question. So first of all, Tony's of course right. We do need a new generation of vaccines. I think Operation Warp Speed was immensely successful.
But then we checked off the box.
Yeah, but we accomplished what we thought we needed at the time. Remember, the theory of the case in 2020 was we build these vaccines, everybody gets vaccinated, everything's better. The pandemic is over. It turned out that the science turned out to be a bit more complicated. The virus turned out to be a bit more complicated. What we need now is not quite an Operation Warp Speed in the same way, but we definitely need a rapid acceleration of development of the next generation vaccines. And we're talking about pan-coronavirus vaccines that are going to be resistant to new variants. We're talking about mucosal vaccines that will actually prevent infection and transmission. We haven't really built very many mucosal vaccines. We've got one, flu mist, it had issues. So my point is,
So what's a mucosal vaccine cost?
Well, there's only, so we don't have
10 billion, 20 billion, 2 billion?
So if you're talking about investments that we need to make, and this is where we're going to need help from our friends in Congress, right? So the administration, we have been working, certainly in the time that I have been there, incredibly hard at looking at the next generation of vaccines, saying what can we do from an NIH point of view, from a BARDA point of view, from an FDA point of view. But we absolutely are going to need a new set of investments. These things will come on eventually over the next 3 to 5 years. If we want to accelerate that and make vaccines that are truly variant resistant or mucosal vaccines widely available, they are going to require, and I don't have an exact number, but probably in the...
But you've asked Congress to give you money that they haven't given you yet, right?
We have asked Congress for, and at this point, I mean, we've mostly asked for COVID response money. We clearly need resources for building this next generation of vaccines. Now, markets work, and they will eventually, as I said, in 5 years, produce these things. If we want them in much shorter time period, we're going to need the kind of investments that Congress needs to help us with to accelerate that. I think the science on this is moving very quickly. We need to have the government play exactly the kind of classic role it plays of de-risking, accelerating the science, making the manufacturing go faster, all the things that can get us to a better place.
Let me ask you a question. There was there were Chinese efforts in developing vaccines, Russian efforts, of course European efforts, and I'm just wondering, and I'm not trying to get a rah-rah answer by any means, but I'm just interested in the state, the ecosystem of science in this health development sector of the United States. Are there aspects of it we should be worried about or concerned as we look, because in a way, developing a COVID vaccine is a national security issue.
Absolutely.
And it is not trivial. And the resources needed are huge. And there are potential strategic gains that other countries might make if they outperform the United States. How secure is our science ecosystem today?
That's a great question. And I actually think the way you framed it is really, really important. Let me make kind of 2 points on this. One is people often say, how did we build these vaccines so fast? It wasn't that fast. Actually, we'd had 15 years of investments that got us primed to build vaccines. Again, not taking away from Operation Warp Speed, which was terrific and was very helpful and successful, but a lot of science had gone into it. We have got to continue doing those kinds of investments. When we were talking about mucosal vaccines, let's talk about that as a national security issue. Obviously, we're talking about that for COVID. But once we figure out how to really build high-quality mucosal vaccines, and then build a platform for manufacturing, the next respiratory virus, which may be natural, maybe a biological threat from a rogue nation, when it arrives, if we have made the investments in building these things, it's going to allow us to build mucosal vaccines way, way faster against that next pathogen. Those are the kinds of investments we've made in the past. I hope that we continue making those kinds of investments because we don't know when they will pay off. But when they pay off big, as these mRNA vaccines did.
Now, I haven't followed it all that closely, so I might botch this question. But one of the things I'm interested in is what do we do next round? We'll be smart. Former Senator Bill Frist was part of a simulation playbook exercise. You know, we had Rick Bright and other people in previous years that were part of a whole, you know, simulation playbook of what we needed to do. And then we had a pandemic hit, and we didn't do all the things that we had been educated to do. Are we getting it right in monkeypox? And what is this supply sitting somewhere that we're not? I mean, there's a lot of controversy over whether our governance and inspectors are allowing the flow of vaccines. And, you know, I guess the big question, my friend, is, are we botching it again?
I don't think we're botching it again. I mean, I think, first of all, very different. People love bringing up, oh, this looks like COVID all over again. It's not like
Well,
COVID.
I'm not sure.
No,
Yeah,
and I
I'm
want to
asking
explain
innocently,
why,
yeah.
right? I mean,
Yeah.
first of all, with monkeypox, this is a virus we know. Remember, in the first 2 months of COVID, or 3 months, 4 months,
We know it, but it's expanding like crazy.
no
Yeah,
one,
yeah,
I know,
yeah, yeah.
I know, but in the early days of COVID, no one could get a test. We have widespread availability of testing. It's
Right.
a really critical part of getting this disease under control. In terms of these vaccines, we had some sitting in a national stockpile. The moment we got to about 50 cases in the US, we immediately said, all right, let's get as much vaccines here. We had about 800,000 sitting, finished in Denmark. Inspectors went over, checked out the plants. They're running some basic assays. My expectation is that's going to be done in the next few days, within the next week or so. Those doses will become widely available. The point is, we are moving very quickly. I mean, just there's no comparison to what happened with COVID.
And are you responsible for that also?
I am not. I am not.
Is there another coordinator for that?
First of all, CDC is the lead agency, obviously. We have an office within the National Security Council that deals with this and kind of helps coordinate it from the White House. So Raj Punjabi runs that office. You know, obviously, as a senior public health person in the White House, I end up giving advice and getting involved, but this very much run out of the National Security Council.
Let me ask you, you know, kind of finally, and I know this is kind of a soft question in a way, but I'm interested, someone in your role, obviously earnest, obviously trying to remedy a big public health crisis. You know, I am a critic of our lack of investment in public health infrastructure. What do you need from those people listening right now? There are ton of people listening online. You know, a lot of people I know. Do you need them to lobby Congress to give you more money for the next virus or vaccine? Do you need people to go into community? I mean, what are the elements that are missing? I mean, you know, I'm a harsher because I'm a storyteller. I'm always interested in who the heroes in a story are and who the villains. How does this community help you with the villains in your story?
I don't know if there are very many villains. I mean, the way I look at it is, what do we need? So first of all, this pandemic is not over, and we need to stay on the front footing. I mean, part of the reason why things for many people feel like, oh, they're not so bad right now, is because we are being very aggressive in countering the virus with vaccines, with treatments. If we took our foot off the pedal, we're going to see this virus come back in a way that's much more dangerous. So we've got to stay on that front footing and continue fighting this thing. Second is,
and that means globally too, right?
You know, every variant that has hit the United States came out of it was first identified elsewhere. The idea that you have a domestic-only approach to a global pandemic makes no sense whatsoever. So until we have a truly, and the administration has been very aggressive on this with vaccines, with requests, but again, our friends in Congress haven't always been willing to fund the global stuff. I think that's a mistake. But there are a set of lessons here about the importance of having a public health infrastructure, having good data systems. And the problem is, when you're not in a crisis, not investing in those things is not a big deal. You don't notice. And the moment a crisis hits, you realize, oh my God.
You have a heart attack.
Yeah, and by the way, we have models for this, right? We have the military. We invest in our military. Most days, thankfully, we don't need to use the full force of the military. But we are really thankful they are there, and we're willing to make those investments. We got to do the same thing with public health as a health security. Make the investments, knowing that hopefully we'll never need to use it. But if we do, we're ready.
Let me ask you one final question. When the coronavirus hit, the world seized up. We saw vaccine nationalism emerge, and countries weren't sharing with countries. We saw a massive race and hijacking of N95 masks, and you know, N95 masks going for $2,000 on eBay, and we saw an insanity, concern about where our active pharmaceutical ingredients were made, mostly overseas. In this case, has there been any rationalization of that world, or is the private sector now in a place where the provisions we need in terms of a crisis are there dependably, or are we going back to a place where having that kind of redundancy built into the system is something we're not going to pay for?
Well, this is a very good question, and this is a question that I talked to a lot of our friends on the Hill about. So right now, we just made a decision to pull money out of having enough PPE in our strategic national stockpile to pay for vaccines for this fall. That is not a trade-off I wanted to make. But if the choice was have vaccines for elderly people in the fall or have enough PPE in our stockpile,
You're going to go vaccines.
We go vaccines, but let me tell you, the idea that we're not going to fill up our stockpiles with PPE for the next crisis seems like a really bad idea. So already we're starting
If you want to do 800 words for the Hill on that, I can get it placed.
You know someone there?
Yeah, I do.
Okay.
Yeah,
So this is what happens when the acute sort of the phase of the pandemic where everybody was on board that we needed to make these investments. As we have made progress, there are people who feel like, we don't have to invest anymore. And then you get into this mode of already starting to take your eye off the ball on investments. I think that's a huge mistake. I think we need to make sure that we have the kind of stockpile redundancy capacity to get us through the rest of this pandemic and obviously be prepared for future ones.
Let's give a hand to Ashish Jha, White House Coronavirus Response Coordinator.
Thank you.
Thank you so much. What fun. I hope you'll come back.
I would love to.
Thank you so much.
And that brings us to the end of today's program. On behalf of the Hill and our sponsors, AdmaVed, Protect the Promise, Emergent Biosolutions, and the Butterfly Network, we would like to thank everyone who joined us in person and virtually. If you missed any of the conversation today, it will be uploaded to thehill.com shortly. Thank you so much and have a great rest of your day.